Hi everybody, welcome to 212, this non-opioid analgesics. We're talking about the COX inhibitors. Let's get started with our continued discussion about pain. We're going to talk about classes of drugs to treat inflammation and fever, compare action, adverse effects, and interactions of aspirin and other NSAIDs, and compare and contrast the COX inhibitors, selective and non-selective, COX-1 and COX-2 inhibitors, and then we're going to talk about using DMARDs for treating rheumatoid arthritis. Remember that DMARD is disease-modifying anti-rheumatic drugs. So the classification of COX inhibitors, there's two classes. First, those with no inflammatory effect at all. That would be like acetaminophen, which is not really an NSAID. It doesn't have any anti-inflammatory effect. That's Tylenol. Some books call it an NSAID, but it acts centrally. It does not act any other way. So it doesn't have anti-inflammatory effect. It's not an NSAID. And the second class of COX inhibitors with anti-inflammatory include the NSAIDs and salicylate, which is a class of its own. Aspirin is in. It's really not listed as an NSAID, but it still is an NSAID. So aspirin does belong in the NSAIDs group. The book lists it as a salicylate class. So you have first generation non-selective that both inhibits COX-1 and COX-2, and then you have second generation selective COX inhibitors, which primarily inhibit COX-2. So then this is a nice table that I stole from Mark. It might be in your book this way as well. The two types of COX. COX means cyclooxygenase, and there's two types, COX-1 and COX-2s. The book has an illustration and a breakdown of what COX-1 and COX-2 does. The cyclooxygenase enzyme results in synthesis of prostaglandin, and it used to be called a prostaglandin inhibitor. Prostaglandin is equal to a major component when we have the inflammatory response activated. It prevents formation or inhibits this, and so it therefore can prevent pain and inflammation from happening. So we have the two types. COX-1 is the good one in all tissue. It does protective things, some housekeeping things, decreases gastric acid, increases bicarbonate, increases the mucus so that the acid is not hurting the intestinal mucosa, maintains submucosal blood supply. So those are all good things. They all prevent ulceration, and the kidneys, they like lots of blood to stay healthier, and so this enhances the renal blood flow and promotes vasodilation. It helps platelets stick together. That's what platelet aggregation is. So this is necessary for us to stop bleeding, and so it helps to inhibit peptic ulcer disease, gastric erosion, bleeding, no platelet aggregation. No, that's not right. It does make platelet aggregation because that's how you prevent bleeding. And then renal impairment, it's not inhibiting that. So it helps with prevention of MI and stroke because of these things happening. Okay, so when we inhibit COX-1, then we are increasing our chance for getting gastric erosion, peptic ulcer disease. We're going to have more bleeding because the platelets aren't aggregating, and less blood flow to the kidneys, so some renal impairment, and that's going to prevent MI and stroke with inhibition of COX-1 because of that platelet aggregation. So you have a decreased risk of thrombotic MI or stroke. And then COX-2, they aren't around in the tissue normally until there's injury to the tissue, and that results in formation. You have to have that local point to form the COX-2 to synthesize the prostaglandins. So this brings in the inflammatory response and phagocytic cells and other cells that are helping to take care of your body when there's inflammation. So you get edema, pain and redness with this inflammatory response starting. So when we want to inhibit this, it'll decrease the pain. It also will decrease fever. It sensitizes the pain receptors. It helps the kidneys, but it inhibits the anti-inflammatory, so you get decreased pain, decreased fever. You'll get renal impairment when it's inhibited, both COX-1 and COX-2. So that's a problem with both selective and non-selective COX inhibitors, is the renal impairment. So you get both good and bad effects. Okay, so aspirin, acetylsalicylic acid, is one of the oldest, most potent anti-inflammatories. It's non-selective COX-1 and COX-2 prostaglandin inhibitor, so it suppresses the inflammatory response. It decreases all the phagocytic cells and all the cells that are kind of part of this inflammatory response, so it helps with pain and inflammation. It provides analgesia. It acts in the peripherally to suppress prostaglandin, which decreases the pain. It works at the site of injury. So it prevents sensitization of pain receptors, and it decreases the inflammatory response, so you have less pain. Opioids work centrally. Tylenol works centrally. And then this is used for joint pain, which is arthralgia, muscular pain, which is myalgia. It works on headaches. Sometimes for arthritis we're using it, for generally for mild to moderate pain relief. Okay, so aspirin is also used as an antipyretic. It works on the brain to inhibit pyrogen-induced synthesis of prostaglandin. So it doesn't tell it tells the hypothyroid not to increase the temperature. That's what it's doing. So this is specifically not used for children. It's a risk of producing Reye's syndrome, which we talked about in first semester, has some implications for that. So basically they give the general, just do not give children aspirin, but it's with viral illnesses, chickenpox or the flu. Sometimes that's how they figured out that this Reye's syndrome was happening. So basically don't give it to children. It suppresses the platelet aggregation. Thromboxane, which is TXA2, is made with COX-1, and that equals the platelet aggregation. And so if you're blocking COX-1, this prevents the thromboxane and the clots from happening. So this is how we prevent MI and stroke, specifically by not having a lot of clotting. No blood flow back to the heart or brain. I don't know what I wrote there. Oh, blocking. So it's preventing MI and stroke because the blood flow, the clots, are not going to be blocking vessels in the heart or brain. Okay, so using aspirin also, it irreversibly inhibits COX-1. So once aspirin does this, the molecules are useless. It doesn't wear off, and then the platelet aggregation comes back up again. It lasts about a week, the life of the molecule. So daily aspirin maintains this platelet aggregation, and in order to reverse it, you usually are advised to stop it about 1 week before surgery. Okay, but now they have these guidelines for the physicians to do the risk-benefit ratio. So the risk of MI and stroke, sometimes for certain patients, it might be better to take the aspirin right up through the surgical time just to keep those risks down of making any clots. It's kind of up to the MD to advise the patient, but it's this irreversible inhibition of the COX-1 that lasts about a week. Okay, so let's go on to adverse effects of aspirin. We know that the gastric upset is number one. Remember, the two things we're inhibiting the COX-1 so that we don't have that stomach protection. That's decreased. And then aspirin is also a direct irritant to gastric tissue. So you have a big risk for GI bleed, especially if you're taking it for a long time or if you have a higher dose. It helps to take it with a proton pump inhibitor to suppress that acid production. Misoprostol is a synthetic prostaglandin. You get COX inhibition and the protective prostaglandin with this kind of a combo product. Renal impairment. For long-term or high dose, you get renal impairment. And you got to think about, how do you recognize that the kidneys aren't working well? Creatinine levels is the primary way that you're going to see dysfunction of the kidneys. The BUN also it might be affected. Also oliguria, no urine making, retention of fluid, weight gain. Primarily you'll look at creatinine, but you've got to be aware of these other things. Alcohol use will exacerbate the ulcer risk. Smoking increases the ulcer risk. History of ulcer is going to increase your chance of having this gastric problem. So you need to get a good history with the people that are having to take aspirin as a long-term medication or at higher dosage levels for whatever reason. The adverse effects with pregnancy. The old school category C or D depends on the period of pregnancy. It's category D during the last trimester because of the risks of bleeding and the GI problems, and postpartum bleeding you can have because the clots are inhibited. It can also suppress contractions because labor is caused by prostaglandins and we're inhibiting that. So inhibiting or prolonging labor. And fetal compromise, there's a risk of premature closure of the ductus arteriosus. You also have the risk of intracranial hemorrhage during birth trauma because of having the aspirin on board. So that's kind of the older thinking, and now because they do this risk-benefit ratio, and we're so worried about any kind of hypertension for pregnant ladies. So sometimes those with pregnancy-induced hypertension or preeclampsia, they might be taking some aspirin to decrease risk of this. So in practice you might see it, but probably for any kind of testing purposes, it's not indicated for pregnancy because of the things we just talked about. Okay, so now, oh, we just did this. I talked all about this without flipping the slide. So, not for pregnancy. There's your ductus arteriosus, intracranial hemorrhage, low birth weight even. Okay, so now we're on to drug interactions. With warfarin, that's a blood thinner, and aspirin, of course, we know is decreasing that platelet aggregation, so now you have doubled up anticoagulation effects, really the blood thinning effects. With glucocorticoids, it can, using with aspirin or NSAIDs, you have that increased risk of GI ulcer problems. NSAIDs, like ibuprofen, inhibits the anticoagulation effect. COX-1 and COX-2 are inhibited, but not binding irreversibly like aspirin. So you can go back to aggregating again when you're taking ibuprofen. So taking it at the same time as aspirin, sometimes you won't get that platelet aggregation inhibition because ibuprofen is blocking the effects there. So within, let's see, so you'd want to take your dosing within 30 minutes of aspirin or 8 hours of aspirin dosing, there's inhibition of platelet effects of the aspirin. So you don't want to take both of those together. You want to use Tylenol if you need pain relief along with your aspirin, or you want to take it after a couple of hours so that aspirin can be absorbed and get to be doing its platelet aggregation properly. So you want to space that and know that if you're taking aspirin for blood thinning, that you have to be aware to take it apart from your ibuprofen if you're prescribed or have to take ibuprofen for other reasons like just the pain effects, so that it doesn't mess with your blood thinning capabilities. Okay, so now we're on to non-aspirin first generation NSAIDs. We're talking about ibuprofen, COX-1 and COX-2. No, I'm on the wrong slide again, sorry. We're talking about COX-1 and COX-2, the inhibition is reversible with the non-aspirin first-generation NSAIDs. The anti-inflammatory use is this non-aspirin class, first-generation, antipyretic use, analgesic use. So you'll see it used for things like rheumatoid arthritis, osteoarthritis, fever, any kind of inflammation that's an itis, dysmenorrhea. So some things are more effective for certain people than other things, like naproxen may be better than ibuprofen for the kind of pain that you're using it for, or inflammation that you're using it for. Toradol, it has a restriction. You can't take Toradol longer than 5 days. Let's see. Increased risk with GI problems. Ibuprofen has less GI problems compared to Toradol, but you want to balance the adverse effects and the increased risk of ulcer and the efficacy of that medication for each person that they're taking it. You might have a cross-sensitivity to aspirin. So when you get other NSAIDs, that's not a good choice. The selective and non-selective increases the risk of MI and stroke. The non-aspirin first-generation NSAIDs, we're not sure about. I don't know what that says. I'm sorry. These notes that I wrote are quickly degenerating my handwriting, so I couldn't read some of this notes. Let's see. Aspirin is the protective for risk of MI and stroke. Most of the others increase your risk of stroke or MI. And then we have the category C and D. So they're not sure some of the other NSAIDs are safe for pregnancy, is what we're getting to. There's the screen. Cross-sensitivity to aspirin. It increases your risk for stroke, MI, I think 12% as a group higher. 12% higher as a group when you're taking these types of NSAIDs. And generally not safe for pregnancy. Okay, so ibuprofen, Advil, Motrin is the first one, has less stomach upset than aspirin. Let's see, less GI. It's used for fever, pain, inflammation. The book says your max dose is 3,200 milligrams a day, but in use, it usually stops at 2,400 milligrams a day. So if you think of 100 milligrams per hour, that's the dosing. So you might see it at 400 milligrams 4 to 6 times a day, or 600 milligrams 4 times a day, 800 milligrams 3 times a day. You might see different dosing there. Another drug is ketorolac or Toradol. It's a good NSAID. It comes IV, IMPO, lots of routes. It has minimal anti-inflammatory effects, but the black box warning on this one is no more than 5 days of use. And it's not for long-term regular basis use. So it's just a short-term NSAID to take. Okay, then we're going on to indomethacin, which is Indocin. This drug, this is another NSAID that's effective for gout or gouty arthritis. This one you might see combo products made up, naproxen and Prevacid. COX inhibition causes stomach problems, so they put a protein pump inhibitor plus the naproxen, and you get the effect of both. And then diclofenac and misoprostol is with a synthetic prostaglandin for people needing long-term use for, like, think of that Arthrotec, so you'll probably be using it for some kind of arthritis, osteoarthritis, or rheumatoid arthritis. It's putting a strong NSAID that could cause stomach problems with the protective prostaglandin part. And then aspirin and Maalox, ascriptin. You got the NSAID aspirin plus Maalox to protect the stomach. And so this one, it's convenient, but it's much more expensive, so you might not see that prescribed. But if people are having trouble, then they may get to switch over to that kind of drug to help them, especially with long-term use. Okay, let's see if we're on to second generation NSAIDs. The COX inhibitors were this one. Let's see. It first came out a few of them, and now it's down to just one selective COX-2 inhibitor. It doesn't have any platelet aggregation inhibition. So what happens is it increases your risk of MI and stroke. There was more in the class, but many suits later because of people having MI and stroke issues. Now there's only one on the market, Vioxx. It's a COX-2 inhibitor. It doubles your risk of MI and stroke, greater than that 12% like the other group we just reviewed. Still have the risk of ulcer, but not as great with NSAIDs like aspirin. You have a risk of renal problems due to COX-2 inhibition. So Celebrex, or celecoxib, is the only one. Oh, Vioxx was the one that was implicated in a lot of problems earlier, but this is the one that's still used once in a while. It's used for arthritis, used for acute pain, dysmenorrhea. It's for short-term use, and the guidelines tell to use the lowest dose possible. So they recognize that there's an increased risk of MI and stroke. It's not as safe, so be sure to use it carefully, short-term use. It might enhance warfarin effect. It increases warfarin levels. Doesn't act on platelet aggregation. It just increases the warfarin levels. And sulfonamide based medication. So if you have a sulfa allergy, you're going to be allergic to this one as too, so you got to make sure you check that with patients taking that drug. Now we're on to acetaminophen or Tylenol. It's got analgesic and antipyretic classification. It inhibits prostaglandins. It works in the CNS, not peripherally, so there's no anti-inflammatory properties with this. And it comes in a lot of combos, Lortab, Vicodin, Percocet. You might see it combined with some of those medications, NSAIDs. NSAIDs plus opioids. It's a popular drug to combine with other pain medicines because of its analgesic antipyretic effects that act centrally. Let's see. Inhibits prostaglandin in the CNS, not peripherally. Okay. Let's look at the drug interactions with the Tylenol. Alcohol is a big one. We know its effects on the liver. It's safe to take Tylenol if you don't have any pre-existing liver problems and if you're not using alcohol any. So you have a greater metabolism of acetaminophen via the minor pathway when you do use a lot of alcohol. So it results in a greater amount of toxic metabolites, and you have a greater toxic metabolites with acetaminophen damages the liver. So drinking lots of alcohol or a history of a lot of drinking, they may already have liver damage, and you have to be wary of using Tylenol with that. And with warfarin, it inhibits the metabolism of warfarin, so it makes more warfarin hanging around, and the effects are going to last longer. So you have increased bleeding effects, an increased risk of bleeding taking Tylenol with warfarin because of this going through the liver. Okay, we're going to talk about osteoarthritis. This is just a quick review of the medications used for taking care of osteoarthritis: Tylenol, NSAIDs, aspirin, opioids because you still have pain, joint injections. Those things are all useful for osteoarthritis. Let's see. I don't know why I wrote missing acetaminophen because it's on there. It's okay for pain, but with oh no, that's for rheumatoid arthritis. That's why. Because osteoarthritis is this joint damaging issues, you might just be using Tylenol for pain, knowing that you don't really have a lot of inflammation going on in there. When you get to rheumatoid arthritis, this is where you have the joints all inflamed because we have the immune response going on, like self-attacking of your joint. And so this one, we're going to use NSAIDs, we're going to use DMARDs, which are disease-modifying rheumatoid arthritis drugs. We are missing Tylenol because the goal with rheumatoid arthritis is to decrease this inflammatory response. So of course glucocorticoids are on here because they give that decreased inflammation. NSAIDs start with them first because they're over the counter, they're easier to get a hold of, they work pretty well. Pretty immediate work. DMARDs take weeks to months to get working, and so they might be on NSAIDs while the DMARDs are getting working, and glucocorticoids needed to add as needed as the disease is progressing. Okay, we're going to talk next about some non-biological disease-modifying anti-rheumatic drugs. Methotrexate or Trexol. This one is for rheumatoid arthritis and also treats some cancer types. It's a first line for rheumatoid arthritis. You can take it one time a week, but it takes 3 to 6 weeks to get going, so you're going to be taking NSAIDs at higher doses, maybe acetaminophen. Higher dose NSAIDs are required for the anti-inflammatory effects. Rheumatoid arthritis has this inflammatory response, but we see that 80% of the people will improve with this methotrexate, and it's a very effective medication. It has significant adverse effects. GI problems, ulceration is a big one. It's hepatotoxic, pregnancy category X, which means will cause fetal death, congenital deformities. It's category X, there's no risk-benefit ratio for pregnant women. So do not get pregnant while you're taking methotrexate. This drug will be very dangerous. It causes bone marrow suppression. We know that the inflammatory response has cells that are coming to attack because it's reading your tissues wrong. But anyway, this interferes with this immune response, so it's going to suppress these cells that are acting for inflammation. And then a second line drug is sulfasalazine or azolfidine. It's got some daily dosing. For people who are having trouble with the methotrexate, this is a drug that they can use. The adverse effects are GI upset. They might have to use enteric-coated kind, or split the dose. Instead of taking one big dose, take it 2 times a day in 2 lower doses to get the same amount. You can relieve it relieves some GI problems. Other issues with this is you might have a rash, some bone marrow suppression, just not as much issues as with methotrexate. It's a safe alternative, but it's not as effective. You see improvement in about a month, and you have to use NSAIDs up until then. Okay, now the biologic DMARDs. TNF is tumor necrosis factor. This is an antagonist that blocks tumor necrosis factor. So it blocks the action of it. This is a substance that causes inflammation. We got a lot of these things going on during the immune response. With rheumatoid arthritis, it's used for rheumatoid arthritis, Crohn's, ulcerative colitis, psoriasis. All of these things are sort of immune diseases, overactive immune response disorders. Let's see, rheumatoid arthritis, ulcerative colitis, psoriasis. So we have etanercept or Enbrel. You have infliximab or Remicade, and adalimumab or Humira. And you might have heard of some of these, TV advertisements and such. They all block tumor necrosis factor. So the risk is really big for increased risk for getting a serious infection. So if you've had TB or possibly infected, they're having really to check you for that. It weakens your immune response. That's what's causing the damage in like rheumatoid arthritis. Taking NSAIDs at the same time is okay. Taking methotrexate at the same time is okay. Sometimes it's used in place of methotrexate. It depends on what's effective for the patient. And this is the class that's effective for treating rheumatoid arthritis. So some rheumatoid arthritis treatment considerations. You might be using multiple agents. You might have the NSAIDs on board, tumor necrosis factor antagonist, and methotrexate. You might have I can't say this one either, hydroxychloroquine or Plaquenil, which is also effective for rheumatoid arthritis. A combo of pain and inflammatory medications, and you got to weigh pain versus inflammation. Sometimes you're going to see opioids used or other medications for pain. Opioids are good for chronic pain. You might see tricyclic antidepressants, selective serotonin reuptake inhibitors, SSRIs. All of those can be used for chronic pain. Opioids treat pain, and we might use the tumor necrosis factor antagonists and methotrexate all along for inflammation. Other uses, we already said for rheumatoid arthritis, psoriasis, etc. Lupus, also another one that this might be used for. Okay, and then we're on to hydrocortisone, or Solu-Cortef. This is an adrenal hormone, a corticosteroid. It can be used to replenish your hydrocortisone level if your adrenals aren't working properly. Increased doses are taken, higher doses than our body physiologically would make to decrease the inflammatory response. So normally your body is making this. It's a stress hormone. The adverse effects include water retention, some CNS effects, anxiety, insomnia, sometimes depression, the cardiac effects, tachycardia, high blood pressure, osteoporosis because it weakens the bones with long-term use, hyperglycemia, peptic ulcer disease. We know we have gastric ulceration with anti-inflammatories. The cortisol levels go up with stress. This is normal for us. You think about the things that happen when you have stress. Anxiety, insomnia, high blood pressure, tachycardia, increased blood pressure, all from a stress hormone. These are all physiological signs of stress, same as the adverse effects with when your cortisol levels go up. So it makes sense because it's a stress hormone. So with teaching, you want to remember, this is not a drug that you're going to be using as a PRN basis. Oh, I really hurt my knee. I'm going to take I'm going to take some hydrocortisone. It's not used that way. It's not used for acute pain. It's used to decrease inflammation and pain with long-term use because it's decreasing the inflammation. You don't want to stop this suddenly. We give it at a higher dose than your body normally makes. So that means the adrenals are getting the signal that they don't need to produce cortisol. So if you stop this drug suddenly, then there's absolutely no cortisol being made in your body at all. And so you're not getting any effect from any cortisol until these adrenals kick in again, which takes a little while. So this drug is always tapered off over days or weeks. It depends on the dose you've been taking and how long you've been taking it. So remember, you should not stop this cold turkey. You need to taper off. Also, you should increase vitamin D to prevent the osteoporosis. Remember, you got to make sure you're getting enough vitamin D to make sure the calcium's getting absorbed and to decrease the risk to bones. Okay, that's all I have on this. I think that there's one place where I want to review on the COX, review this little table, and know that when you're inhibiting COX-1, you're not getting the protective qualities. So you're going to have gastric erosion, you're going to have bleeding, you're going to have the kidneys not getting good blood flow, so some renal impairment, and with a platelet aggregation being inhibited, the good part of this is it's going to prevent MI and stroke. So remember, it's both good and bad things when you inhibit that COX-1. And with COX-2, it's working after you have tissue injured, and it helps with this synthesis of prostaglandins in the brain. It's going to increase the perception of pain and fever. With the kidneys, it's going to support renal function. Peripherally, it takes care of inflammation by sensitizing the pain receptors. So if you inhibit COX-2, you're getting anti-inflammatory effects, and you're going to get alleviation of pain, and you're going to get reduction of fever, but you're going to have renal impairment by inhibiting COX-2. So I know when I tried to mumble my way through that, I might have confused you guys. Just go back to this and in your book where the table is to review it. And that's all I have. Thank you all very much.